The following phases summarize the female sexual response. So we first have excitement, where you have uterine elevation. You have elevation of the uterus with that. Then you have the plateau, where you get vaginal expansion. Then you have the orgasm, which is where you have the uterine contraction. And lastly, you have resolution. The main point to drive is that occasionally uterine elevation is mentioned as a detail regarding female sexual response, and this is not something that occurs during orgasm, but instead during what phase? That's right, the initial excitement phase. Let's take a moment to review the male reproductive anatomy. So, male reproductive anatomy can be summarized by the mnemonic 7-up, which is a mnemonic for the path that sperm takes during ejaculation from the seminiferous tubules, so it would be in the testes, the epididymis, then the vas deferens, the ejaculatory duct that you can see it's right here, then nothing, then the urethra, see here, and finally the penis. Most importantly, be aware that the sperm mature in the epididymis and are stored there until the ejaculation occurs. So to what extent does sperm mature in the epididymis? Almost entirely. But where do sperm reach peak maturation? The answer is actually in the vagina. Vaginal secretions enable sperm to reach capacitance, a term that you should know, which is defined as augmented motility and full maturation. Now, when a woman is ovulating, her high estrogen levels increase the NaCl content of her secretions, thereby creating a ferning pattern that is conductive to sperm capacitance and motility. Now, in contrast, higher progesterone levels approaching menstruation decreases NaCl content of secretions, leading to a beating rather than a ferning pattern. This is not conductive to sperm capacitance. In terms of the vas deferens, be aware that it is ligated in vasectomy, which is a permanent sterilization. If you guys remember from biochemistry, it is also exceedingly high yield that the vas deferens is absent in many patients with cystic fibrosis. Remember that one. In fact, heterozygosity is absent for a CF mutation, most notably the delta, I'll write it for you, delta F508 mutation, which yields 75% priority likelihood of congenital bilateral absence of the vas deferens. So in a question, if they mention infertility in a couple and a semen sample reveals absent sperm, cystic fibrosis in the man is usually the answer. However, if they mention that sperm are present, but that they are merely non-motile, then the answer would be Carter-Jenner syndrome, which is a disorder of ciliary dyskinesia resulting in situs inversus, chronic respiratory infections, and infertility, because the immotile sperm in men and ectopic pregnancy in women due to the lack of fallopian tube ciliary function. Lastly, why do women get UTIs more often than men? You need to be aware that it is because the longer urethral length in men decreases the proclivity for UTI development. UTI development in a man almost always points towards some form of anatomical abnormality or underlying pathology such as posterior urethral valves, vesicular urethral reflux, or BPH. Here's another flash quiz for you. During ejaculation, sperm in the vas deferens come immediately from where? If you remember a mnemonic, it would be from the epididymis. Good. Now, I'm sure any guy cringes at the idea of this, but we all have to know it for the exam, so bear with me here. Always suspect urethral injury if there's evidence of blood at the urethral meatus. Note that these can also be injured iatrogenically, unfortunately, during, for example, a catheterization. In the posterior urethra, the membranous part is prone to injury from what type of fracture? It would be a pelvic fracture. I mean, it's in the area, right? Whereas the bulbar part is prone to injury by blunt force. Any of these injuries can cause urine to leak where? In the retropubic space. All right. Now, the anterior urethra can be a risk of damage secondary to the perineal stratal injuries. So if the fascia is torn, then urine's going to leak into the superficial perineal space. As you can see here, this is a urethrogram of the urethra showing injury. So you can see the fracture spot right there. Now let's talk about the male sexual response. In terms of the male sexual response, the pneumatic, point and shoot, links P, point, parasympathetics, with erection, and S, shoot, sympathetic, with emission. Now, under the parasympathetic system, the pelvic nerve triggers NO release, which increases what? CGMP, which is called cyclic GMP, thereby relaxing the smooth muscle in the blood vessels. As you can see in the image here, this increases blood flow. There you can see the veins are dilating. You have the increased blood flow through the corpus cavernosa, corpus spongiosum, and bulbospongiosis that all contribute to maintenance of erection. You may remember from the MSK chapter that nitric oxide increases CGMP as it activates guanylyl cyclase. This then activates PKG, leading to dephosphorylation of myosin light chain kinase, therefore resulting in smooth muscle relaxation. This is how some of the erectile dysfunction drugs we'll discuss later on work, as they are phosphodiesterase inhibitors, thereby stopping the breakdown of cyclic GMP. So eventually you get the release of norepinephrine, causing a calcium influx and smooth muscle contraction, therefore vasoconstriction, which will stop the erection. In terms of ejaculation, the sympathetic system will activate to constrict the blood vessels and allow semen to flow through. So is this entirely an autonomic process? So ejection and emission are autonomic? No, because you also have the somatic nerves, which play an important role. Because what's the only thing we didn't talk about is ejaculation. Ejaculation is somatic. During ejaculation, semen is ejected by the rhythmic contractions of the bulbospongiosis muscle via the spinal reflex through the pudendal nerve, which is a somatic nerve. Here's a flash quiz. During erection, nitrous oxide causes an increase in concentration of what intracellular molecule? CGMP. Let's finish up this section with seminiferous tubules. So spermatogenesis takes about 9 weeks and is a process that occurs in the seminiferous tubules of the testes. Sperm becomes further developed as they get farther from the basal lamina. So they start as spermatogonia, then become primary spermatocytes, secondary spermatocytes, early spermatids, late spermatids, and finally spermatozoa. We'll talk more about that in physiology. But be aware that the transition of spermatids to spermatozoa is called spermiogenesis. For some reason, USMLE really wants you to know that. So, spermatogonia. You can see here with the blue arrows, they're the germ cells that keep the sperm supply going. So they line the seminiferous tubules along the supporting Sertoli cells. Sertoli cells that we just talked about, as you can see the red arrows, they're non-germ cells, and they support and nourish the developing spermatozoa, playing an important role in regulating spermatogenesis. Sertoli cells form really tight junctions that comprise what? The blood-testes barrier. The barrier protects the gametes from autoimmune attack. You do need to know this. Now, in contrast, you have the Leydig cells. You can see them in the green arrows. Also known as interstitial cells because, as you can notice from the image, they're in the interstitium. They're not actually inside the seminiferous tubule. So if they show you an image like this one here, you can see that the Sertoli cells run circularly around the blood-testes barrier, forming a nice uniform distribution, whereas the Leydig cells are found interspersed outside of the blood-testes barrier. This histology is really important. Now, Sertoli cells, they also serve an endocrine function by secreting inhibin and androgen binding protein, also anti-Mullerian hormone. Now, inhibin inhibits what gonadotropin? FSH. So the FSH secretion is blocked by inhibin, and it acts as a negative feedback for spermatogenesis. For LH, that would be more towards the Leydig cells. Be sure to remember that on step 1, FSH predominantly stimulates Sertoli cells, and LH predominantly the Leydig cells. Now the androgen binding protein, it helps maintain an appropriate testosterone levels as it sequesters free testosterone and keeps it available at higher concentration within the testes. As for anti-Mullerian hormone, we discussed its effects back in embryology, but for review purposes, remember that it basically prevents males from having female sexual organs. So Leydig cells, their main job is to produce testosterone, as we talked about. The latter negatively feeds back on the anterior pituitary and hypothalamus to inhibit what gonadotropin? As I said earlier, LH. Final fun fact. So the seminiferous tubules are temperature sensitive. High temperatures actually decrease sperm production as well as secretion of inhibin. This is thought to be the reason that male gonads are outside the body and function at a temperature below physiological. In situations like varicoceles or cryptorchidism, the temperature of the testes actually increases and you often see impaired fertility. What's interesting about that is that what cell is actually affected by the temperature? It's the Sertoli cells. The Leydig cells are unaffected by temperature. So testosterone production is not affected. On the exam, if they ever ask about testosterone or LH levels in cryptorchidism, the answer is they are normal. However, sperm production will be impaired, inhibin will be low, and FSH will be high because the Sertoli cells got hit. All right, so we're basically done with the structure of the reproductive system. Please join me in the next section so we can delve more into its function and physiology. Now, let me give you guys a couple questions. So, a 14-year-old boy arrives in the emergency department after sudden onset of excruciating left scrotal pain. On physical exam, elevation of the left scrotum failed to alleviate the pain, and stroking the inner thigh failed to elicit scrotal elevation. Doppler ultrasound shows decreased blood flow through a specific artery and the spermatic cord. Which of the following structures is located inferiorly to this artery before this artery enters the spermatic cord? Answer is the ureter. So, testicular torsion that causes occlusion of vascular flow through the testicular artery leads to acute and severe pain. Physical exam may also demonstrate loss of the cremasteric reflex and a negative Pren sign. It's pretty much what's explained in the stem. So the answer is D, because the testicular artery is located oblique and superior to the ureter prior to entering the spermatic cord. According to Pren, lifting of the testicles relieves the pain associated with epididymitis, but not testicular torsion. Okay? Next question. 57-year-old woman is scheduled for elective hysterectomy. Severing which of the following structures during surgery would most severely disrupt blood flow to the ipsilateral ovary? Is it A, the cardinal ligament, B, the fallopian tube, C, the round ligament, D, the suspensory ligament, or E, the ureter? The answer is suspensory ligament. So the ovarian vessels lie within suspensory ligament. In contrast, the uterine vessels are within the cardinal ligament. The round ligament, like we talked about, has the artery of Sampson, which is an anastomosis between the uterine and ovarian vessels, but mainly you can remember that there's really none in there. The fallopian tubes and ureters do not contain vessels supplying the ovaries.